palatally for the denture, that will prevent the tongue from getting that seal or insufficient tongue space. All of those things. Lisping is typically a new denture problem, not a denture problem that's occurred because of a lot of wear or resorption. So in general, the overview is be systematic. Try to get that full history, try to examine what's going on, test some hypotheses to see where the problem is, come up with a couple of differential diagnoses as to the cause of it, address it with experimentation, either adjustment or easily to remove tines of relines, or talked about adding posterior palatal seal with wax. If after you've done all that, you can't find the problem, don't go to making a new denture, because you don't know what to make differently. And if you don't know what to make differently, you may very well make a brand new denture that the patient is just as dissatisfied with as the one they have now. So you may want to refer to a prosthodontist. Now, if you ultimately become a prosthodontist and you can't figure out what the problem is, you may want to assume that the problem is psychological, because you're not going to make something different if you don't know what to make different. It's just random. Watch for the red flags, right? The patient has an anatomic problem, like they're showing a denture with an obturator there, so somebody has a cleft palate or post-cancer surgical resections. That can be a problem. Maybe there's a diagnosis problem. You don't know what the problem is, so you're making the wrong guess. Maybe the patient can't adapt, or maybe it's just a psychological problem. So try to come up with what's going on with this difficult denture patient. These pictures show a resorbed ridge. Dr. Bayram talked about some of the special techniques you might use to get a denture to fit where there's a resorbed ridge. Patient comes in with a bag full of dentures. A lot of dentists have tried, and as I said, so it's possible that they just jumped at the opportunity to make another set of dentures without first identifying what they were going to do differently. But it also can be a suggestion that this patient is not at all adaptable. It does take a certain degree of adaptability to wear dentures. These are two acrylic objects. They're foreign objects that, while we do custom make them to fit in the mouth, they're foreign objects, and not everybody can tolerate a foreign object in their mouth. So follow the principle, determine the problem. Okay? Tell the patient if you can find something, don't just adjust. Don't jump to adjustment first. Think that, you can correlate the ulceration or the soreness to a spot on the denture. I'll grind on the denture in that spot. Figure out what's going on before you do that. Refer if you can't identify the problem. Don't try the placebo effect. Don't think that you're going to just pretend to adjust a denture you can't find the problem with, because if the patient walked in believing there was a problem, they're going to still have that problem. And at the same time, you make it harder for the next dentist to manage this patient, because they're losing confidence in dentists, because you may believe you did something and you didn't really do it, and all they know is you tried and failed. And so why are they confident the next dentist won't try and fail? Remember, with respect to adaptation, that the older patients take a lot more time to adapt. And in some cases, we see older patients, and they have a lot of broken teeth and root tips, and we're taking them to their first denture, maybe at the age of 80 or 85, and do not expect them to just adapt, hit the ground running with new dentures. And you want to start setting the stage for that with the patient and the patient's family as early as the very first visit. Say, this is not going to be something that you're going to get to easily. You're going to have to work at it. Most people succeed if they do the work, if they try to do it. And don't try the most difficult foods first. Don't get your denture and go out and have a steak first night. Get used to it. Still eat soft foods and gradually work up to the harder foods. And maybe there'll be a few adjustments along the way. And at some point in the middle, between their adaptive skills and the denture being adjusted to their mouth, we meet in the middle and they have comfort. Remember that when there's more teeth missing, there's less adaptation, because they don't have any PDM receptors, right? There's those periodontal membranes that do give us proprioception, etc. So if they've gone without dentures for a long time, that's a hint. They're not going to adapt well because they're going to revert. They're going to take the dentures out when they have a meal. They've been doing that right along. And the first day they get the dentures, they don't fit that comfortably. They're going to take them out, and that sets the stage for failure down the road. So, okay, denture may be the cause of the problem, but the patient response may also be part of the problem. So you can look at what the denture is doing, some of the troubleshooting that we talked about, but you also have to read the patient and encourage the patient and attempt to maybe even modify the patient's behavior and response. So this is, again, referring to showing that you care, showing that you're on the job, working with them, trying to get there together, as opposed to being adversarial, saying, you're not trying, I can't do any more for you. You know, stay with them, be supportive. It makes a difference. So remember when I talked about doing the history, have good interview technique, you're going to find that there's a couple of tip-offs that this may be a difficult case. Bags of dentures, disparaging comments about previous dentists, had a guy who was an idiot or whatever, they say something like that, then you know that they're perfectly capable of saying it about you as well, that they have some of their trust has been eliminated, and that's a problem. And sometimes you may just find the body language, the way they just control themselves, is giving a hint that they're not trusting, that they're cynical, that they're not confident in you. So look for all those hints and manage as you see fit. And if you feel like the case has got too many red flags and sounds like a difficult case, don't take it on. That's the difficult denture cases that become a thorn in the dentist's side that lead some dentists to not do dentures anymore. And you can do dentures and you can be a real help to your patients, but look for the tip-offs. Don't get into the cases that are going to sour you on the entire process. So you want to recognize and acknowledge the problem by using open-ended questions. Let the patient tell you what the problem is. And remember that if you jump to a conclusion and you think that you get the problem wrong, you're not going to fix that thing that needs to be fixed. Okay, let the patient talk. Give them a chance. Watch for those nonverbal clues. Watch for short verbal clues like, and I guess the appearance might mean that they really don't want to focus on it, but that's what they really don't like. And remember also that family members should be present when that's appropriate, because a lot of times the family is actually part of the problem and not part of the solution. So we're going to get them on the team so that everybody's working toward solving this problem. And don't be afraid of questions relating to emotional health. Have you been depressed? Are you living alone? Things like that. So you get to the root of it. You just want to be careful with those kinds of things because you don't want to start to be suggesting to them that you're concluding the problem is that they are crazy. But you do want to sort of get intimate with them in the sense that you understand what's going on in their lives. Let them know what you think, okay? You got to be careful, tread lightly when you're talking about emotional problems. You're not a therapist, you're not going to solve them all, but don't be afraid to address that they may be playing a role. And always, always, always temper expectations. Can't emphasize that enough. Just like making notes in the chart, just like consents, after the fact is too late. Remember at the very outset to temper expectations. This is going to be something that you're not going to get on that day and go out and have a meal, and it's going to be like you never lost your teeth starting on day one. It's unrealistic. Let them know there's an adaptation phase, that there may be some adjustments necessary. Okay? Don't overpromise. I can solve this problem. I figured out what's wrong. I can solve this problem. Be careful. Remember, they've already lost some of their confidence in doctors if they had this done before and it was not successful. If there's a chance the denture is not going to be successful, let them know. We can try this, but I can't promise. If you start to feel like the case is going downhill even in the middle, you still may want to refer or address these problems initially. And don't be afraid to say, maybe the emotional state has to change before we can be successful. I do, in my professional opinion, think maybe you need some help elsewhere before we can continue. So remember, if the bells go off in your head, don't proceed, okay? Make sure you satisfy those concerns that you're developing in your mind before you take on the case. Most patients are not problem patients. I guess it's about 80-85% are satisfied, which is, according to some literature, better than the adaptation of eyeglass wearers. So, some people, they can't wear contacts. Some people can't wear glasses. They only have contacts. But most people are satisfied with both therapies. And just remember, if you have that 15 or 20% that are not easily satisfied, that you set up for that possibility from the outset. Okay? Rule out objective findings first before you decide it's a psychological problem. Don't jump to the assumption that it's a psychological problem. That's why we said the first majority of the lecture was about looking at the dentures and troubleshooting the dentures. And remember, if you do think there's something psychological, try to avoid using words in your charting that are subjective. Stick to the objective kinds of language so it doesn't sound like you're already developing an attitude toward the patient. No, these are cold clinical observations that are entered into your chart. We're going to end it right there. Thanks for viewing this. Goodbye.